Good morning, everyone. In the last class, Dr. Anusha has covered anterior uveitis. In this class, we will be discussing about intermediate uveitis, posterior uveitis, and a few specific types of uveitis which are important. So, talking about intermediate uveitis involves the pars plana part of the ciliary body, the peripheral retina, choroid, as well as the vitreous base. The inflammation of all these parts falls under intermediate uveitis, also known as pars planitis, mainly. Now, this intermediate uveitis involves both children as well as young adults with a specific peak in the second decade and fourth decade, which is also referred to as the bimodal presentation. It affects both genders equally, both males and females, and it also is bilateral in about 80% of the cases. Now, what exactly happens in intermediate uveitis is there is an inflammation of the retinal vessels leading into leakage into the vitreous, as well as there is also development of exudates in the vitreous near the ora serrata. Now, the most common causes of intermediate uveitis are tuberculosis, syphilis, sarcoidosis, and multiple sclerosis. Now, intermediate uveitis does not have any symptoms like pain, photophobia, redness, because it is affecting the posterior segment mostly. So, what all symptoms, whatever we can see, are mostly related to posterior segment symptoms. So, the patient may present with floaters. Floaters is nothing but black spots in front of the eyes, and also there could be blurring of vision. And then the onset can be insidious. Usually, there is usually no acute presentation with intermediate uveitis, and then there is blurring of vision and floaters. Now, what are the other clinical signs of intermediate uveitis? Because it is confined to the pars plana part, so usually the eye is quiet on the surface. There is no anterior segment inflammation usually. Even if it is present, it is very minimal. Now, coming to the features of anterior segment, usually there can be very fine KPs with very minimal aqueous flare. So, later in the vitreous may show inflammation, which is known as vitritis. So, there can be a large number of cells which can be seen floating in the vitreous. This grading can be from +1 to +4, which is the highest. Now, there can also be lots of exudation near the ora serrata. Now, as you can see in the bottommost picture, there are lots of snowball-like opacities in the inferior part of the vitreous near the ora serrata part. So here you can see lots of clumps of exudates called snowball opacities. Now, sometimes what happens is all these snowballs will start organizing and form a grayish fibrovascular plaque known as snow banking. So a plaque-like structure can be formed in the inferior part near the ora serrata. So there can be lots of vitritis, snowball-like exudation, as well as snow banking, and there can also be lots of opacification and condensation of the vitreous. So because of all these, the floaters are mainly due to some stringy, fine or coarse vitreous opacities. So because of all these ongoing inflammation as well as snowballs and snow banking, what happens is there can be condensation of the vitreous, and also there can be very dense opacification of the vitreous, as you can see in this picture, because of the inflammation. So it can simulate a picture of leukocoria. So leukocoria is nothing but presence of whitish reflex in the pupil, and so because of the severe vitreous opacification, there can be appearance of leukocoria. Now you can see in this part there is severe condensation of vitreous, where all the vitreous fibrils are aggregating together to form this vitreous condensation. Usually vitreous is in a jelly-like state or a gel-like consistency normally. So all these things will start happening in intermediate uveitis. Now, there can also be mild peripheral periphlebitis, which is nothing but mild vasculitis, or more specifically There can be venous inflammation of the vessels of the retina. So this is all due to the retina being in close opposition with the choroid and the ciliary body structures near the ora serrata. So whatever inflammation is there of the pars plana, there can also be peripheral retinal periphlebitis near the ora serrata. Okay. Now, how about the course of the intermediate uveitis? So the disease can have a single self-limiting episode, or it can also have a prolonged course with exacerbations, or it can then also be a course without any exacerbations. So it is very individualistic and patient specific. Now, what are all the complications of intermediate uveitis? So any kind of uveitis, you can have a myriad of complications, especially if the course is prolonged and if the course is very chronic of the inflammation. So coming from anterior to posterior, the complications would be band-shaped keratopathy. Band-shaped keratopathy is a band present in the interpalpebral area on the cornea, specifically seen in chronic uveitis. So band-shaped keratopathy is one of the complications of intermediate uveitis. And then going back, you can always have a complicated cataract, always present, followed by secondary glaucoma. They could be trabeculitis, or they could be in later stages, they could be angle closure glaucoma. So all these can occur, as well as because of the ongoing inflammation in the retina, there could be serous detachments, and there can also be tractional RDs because of the organization of all these exudates. And there can also be cystoid macular edema as well as vitreous hemorrhages. Now, again, as I previously told, the main important points to keep in mind when there is intermediate uveitis is syphilis, sarcoidosis, it's tuberculosis, multiple sclerosis, and sometimes definitely toxo. Treatment, usually it is, now there is a specific approach known as Kaplan's approach for treatment. So in Kaplan's approach for treatment, what happens is there is a four-pronged approach. Usually in mild cases, no treatment is required, but when in severe cases, the first level of treatment would be periocular depot steroid, where the triamcinolone acetonide is most commonly injected in a posterior subtenon's manner, and then systemic steroids can be substituted. And if it is not responding to steroids, the second pronged approach would be immunosuppressants. Immunosuppressants like azathioprine, methotrexate, cyclosporin, cyclophosphamide. All these immunosuppressants will form the second level approach. Now, if there is still snowbanking and the snowbanking is not resolving, you can go for laser photocoagulation, or also you can go for cryotherapy to the area of the vitreous base or the area of snowbanking, so that to curtail the further extension. Even if cryotherapy or laser photocoagulation are not helping, then you can go for the last stage, which is a surgical management, which is pars plana vitrectomy. Now coming to posterior uveitis. Now, as you know, there are three parts of the uveal layer or the middle vascular coat, which is iris, ciliary body, and choroid. So choroid forms the posterior most part of the uvea. See, again, as I've said, the choroid and the retina are always in close opposition to each other. So whenever there is inflammation of the choroid, which is known as choroiditis, it is usually inevitably accompanied by an inflammation of the retina too. So usually it is not only choroiditis, but it is usually chorioretinitis. Now, what all can be the symptoms of posterior uveitis or choroiditis? Again, because it is involving the posterior part, it is choroiditis, and so whatever symptoms we get, it will be pertaining to the posterior part. So the anterior segment is usually quiet. It is white-eye, usually very, very quiet, unless and until there is spillover. That is spillover from posterior part to anterior part. The inflammation is spreading from the posterior part to anterior part. Then you will be tending to have also symptoms of anterior uveitis. But usually it is posterior uveitis. Again, to be specific here, if the posterior choroid, whatever is involved, it is involved in the periphery. then you are very less likely to have any symptoms, the patient. And so usually it is an incidental finding, just discovered by chance. But suppose it is involving the more prominent posterior pole areas, the macular area, and other areas, then usually you can have symptoms of choroiditis. The patient will present with symptoms. So again, as I've said, because it is involving the posterior part, it is usually a painless condition with no photophobia, lacrimation, or circumciliary condition. None of these will typically occur. So the most common symptoms again will be all these, especially if the central area is involved. Defective vision because of the inflammation of the choroid. Floaters, again as I've said, any vitreous opacities or vitreous inflammation, anything causing floaters. And metamorphopsia. Metamorphopsia is especially seen when the central macular area is involved, where whatever objects you see, they appear slightly distorted in shape, and also in like for example, the lines which are straight, they may appear a little bit zigzag, or any object can appear slightly distorted. Micropsia is when the objects will appear smaller in size than their normal size. Macropsia is when the objects will appear larger in size than the normal size. And photopsia is when there are flashes of light. Positive scotoma is, suppose you're looking, just imagine you're looking at a normal picture and you can see a black spot somewhere in the picture, maybe in the center. The patient will usually say, I can see the picture, but I can also see a black spot somewhere in the center. In contrast to that, negative scotoma is where you're seeing a picture and parts of the picture are entirely missing. You don't see anything there. Like half of the picture, you say, I can see only this half of the picture, I can't see the other half. That is a negative scotoma. A positive scotoma is where the patient will specifically say that I can see a black spot somewhere in the picture. So now this posterior uveitis, again, as I've said, the signs, suppose there is a mild spillover anterior uveitis, the anterior segment is usually quiet and the eye is wide, but they can be very fine keratic precipitates on the back of the cornea. Now, vitreous opacities are usually present in the middle or the posterior part. Again, this is in contrast to intermediate uveitis, where the vitreous cells or opacities are mostly seen in the anterior half of the vitreous. Here, the vitreous opacities are most commonly seen in the middle or the posterior part. Now, the most important thing to again learn in choroiditis would be identifying a patch of choroiditis. So that would be a distinguishing feature to say it is a case of choroiditis. Now, this choroiditis patch could be either active or it could be healed. An active choroiditis patch, usually as you can see in the picture below, it could be yellowish white or it could be some dirty white or dirty gray in color. You can see it is slightly raised above the surface, and please see that whatever vessels are going through it, you can see the retinal vessels will be coursing over this patch of choroiditis, not under it. If you visualize the anatomy, if you remember it, the retina is the innermost layer and the choroid lies over it. So when you see the fundus picture, the first layer you come across is the retina, underneath it is the choroid. When you're trying to, because you're seeing the interior of the eye. So whatever retinal vessels are seen, they'll be seen coursing over the lesion. So this is how a patch of active choroiditis looks. It looks like this. Now in contrast to it is the healed choroiditis patch. The healed choroiditis patch, there will be usually pigmentation and it is not raised above the surface, it is obviously flat. And because the choroid is becoming atrophic, you can always see the sclera which is present underneath. So again, coming back to basics, the retina, the choroid, and behind it is the sclera. So you can see the whitish sclera which is present underneath, and because of this inflammation gradually resolving, you will find areas of hyperpigmentation or pigmentation clumping. So usually the scarred or healed choroiditis patch usually has pigment clumps, atrophic choroid with the whitish sclera being visible underneath. So again, you can see in this area, in the first picture, this is a healed choroiditis patch. in the central, in the macular area. This is the optic disc, temporal to it is the macula. Here you can see a heel patch of choroiditis with all this pigmentation, and you can see certain whitish areas. These are the scleral part. Now, this is also a case of toxoplasma. What you're seeing here is a heel choroiditis patch. Okay, but what you're seeing here, again as I've described, it is yellowish white. It is raised above the surface, and you can see definitely this vessel is forcing over the lesion. So all these are active or active stage of active patch of choroiditis. This is a healed patch of choroiditis. Now, these choroiditis can be divided clinically into three main types. So the three main types would be diffuse choroiditis, disseminated choroiditis, and focal choroiditis. Now, will come from focal choroiditis. What is focal choroiditis? Again, as the name implies, whatever inflammatory patch of choroiditis is present, it is confined to a very specific localized area. And so, central choroiditis, again, as the name implies, as you can see, this is a central choroiditis involving the central part at the macular area. Suppose here, now you can see these lesions are just adjacent to the optic disc. So these will be peripapillary choroiditis. So again, as the name implies, central choroiditis central, juxtapapillary or peripapillary or juxtacecal, just adjacent to the optic disc. There is a very specific variant known as Jensen's choroiditis, usually seen in young people. So just remember the term. Now, what is anterior peripheral choroiditis? I don't have the picture, but I will try to show you. Suppose, as you know, if you remember again the picture of the sagittal section of the globe, the very mid part is known as the equator. So anything anterior to it, somewhere in the periphery of the choroid, anterior to the equator, somewhere around here, if you have a lesion, that would be anterior peripheral choroiditis. And somewhere just at the equator of the globe, if you have a specific choroiditis inflammation just confined to the equatorial region, it would be equatorial choroiditis. Now, this is a picture of multifocal choroiditis. So, disseminated is also known as multifocal choroiditis, where you have multiple spots of choroiditis here, which are confined, which are small. These are not extensive, as you can see. These are small patches of inflammation, but these are multiple, but they are spread over a part of the choroid, a greater part of the choroid. So all these are known as, this is known as multifocal choroiditis. Now, what is diffuse choroiditis? Diffuse choroiditis is where you know all these patches will start coalescing or joining with each other, and we can see extensive large patches of choroiditis. That would be that would be diffuse or geographic or serpiginous choroiditis. All these diffuse or geographic. So, focal choroiditis, multifocal choroiditis, and diffuse choroiditis. Now, again, what are the complications? Again, very similar. Suppose the inflammation from the posterior part is spreading to the anterior part, you would have anterior uveitis. And then suppose there is long-standing uveitis, you can have complicated cataract. And then you can have, as I said, vitreous degeneration when there is lots of vitritis and vitreous opacities. Again, there could be periphlebitis retinae, which is again retinal vasculitis, or to be more specific, inflammation of the retinal veins. Retinal detachment can also occur. So all these are usually the complications are set complications. Now, again, the treatment would also again be very specific, as in topical steroids would obviously not be so effective in posterior uveitis because they have to penetrate the anterior segment and reach the posterior segment again, going through the lens. So all these topical steroids would not be too effective. So posterior uveitis would also require steroids as the primary treatment to control the inflammation. But what steroids is important are posterior subtenon injection of depot steroids. triamcinolone acetonide again. And it's not responsive, it can even systemic steroids can also be given. And if still not responsive, you can substitute it with immunosuppressive agents. Now, what is the specific therapy? Specific therapy is again very cause oriented. Now, all these posterior uveitis, whatever we have seen, the most common causes are, again, you have to look for tuberculosis, you have to look for syphilis, you have to look for leprosy, you have to look for other causes. So any specific therapy, you'll try to look out for any infectious agent and also try to correlate it with other systemic features. If any are manifesting in other parts of the body, try to correlate it with your ocular findings and then institute specific therapy according to the infectious agent or any other non-infectious agent. It could be anything, not only infectious. So treatment oriented at the ocular inflammation part would be done by steroids and other specific therapy for the infectious agents. Now, coming to some specific conditions, we have read a lot of these conditions, but we'll be highlighting only a few specific conditions here. So the first one is tuberculosis. So tuberculosis can cause a lot of ocular findings, but we'll be restricting it to the uveitis findings. So for tuberculosis, it affects both the anterior part, the intermediate part, as well as the posterior part. So when it is the anterior part, please remember tuberculosis usually produces a granulomatous type of iridocyclitis, where you have your typical mutton fat keratic precipitates which are arranged in the triangular fashion, and they can be iris nodules, there can be lots of aqueous cells and flare. Please recollect that granulomatous is differentiated from non-granulomatous by the presence of large, lardaceous mutton fat keratic precipitates. There can be lots of aqueous flare as well as aqueous cells, and there can also be iris nodules. So all these occur as granulomatous tuberculosis or iridocyclitis can occur. But sometimes there are exceptions. It sometimes can also be present as a very non-granulomatous, very low-grade non-granulomatous type of anterior uveitis can also occur. Again, intermediate uveitis, we have just now read that tuberculosis can also be one of the causes of intermediate uveitis, leading to vitreous inflammation, vitritis, as well as snow banking. Now, what about posterior uveitis? Tuberculosis can cause choroidal tubercles. Just like in your lung, just like how you have read miliary tuberculosis, there can be multiple foci of tubercles also presenting in the retinal choroidal part, in the choroidal part. So there can also be multiple choroidal tubercles, which are nothing but miliary choroidal tubercles. So these miliary choroidal tubercles typically occur in cases of tuberculous meningitis. Okay, so choroidal tubercles can also manifest here. And tuberculosis can also cause multifocal choroiditis. Again, as I've said, posterior choroiditis, we'll try to look for all these common infectious causes like tuberculosis, syphilis, sarcoidosis, leprosy, multiple sclerosis, okay, fungi like histoplasmosis, candida. You have to try and look for all the bacterial causes, viral causes, parasitic causes, fungal causes. So all the causes you'll try to look out for, and if you're not done with infectious agents, you'll move on to the non-infectious causes. Okay. So it can cause choroidal tubercles, multifocal choroiditis, or sometimes it can just cause solitary granulomas. Okay. Now it can also cause, most importantly, retinal vasculitis. Retinal vasculitis is inflammation of the retinal vessels which can lead to exudation. So all these are features of tuberculosis. So this is tuberculous choroiditis. You can see multiple foci of, tuberculous choroiditis here. There are large multiple foci here, and it is spread throughout the fundus. Now, leprosy is again important in the context that there could be a lot of symptoms. Like if you go back to your cornea, interstitial keratitis, one of the main causes is also leprosy along with syphilis. Okay, so what happens in leprosy? Again, there are two main types, lepromatous and tuberculoid. So it occurs more commonly in the lepromatous form. So now leprosy uveitis mostly involves the anterior uvea. So it could be either acute iritis or a chronic iritis. So acute iritis is usually non-granulomatous, and what you can see is just mild inflammation of the iris and its vessels, leading to outpouring of exudates from the inflamed iris vessels, which become leaky. So there is exudate formation in acute iritis. What happens in chronic iritis is whatever leprosy, Mycobacterium leprae organisms are there, they will start invading the iris stroma, and then they will start forming the granulomas. Okay, it will be a granulomatous inflammation, and then there will be formation of something known as iris pearls. So there is important term is lepra pearls or iris pearls will start forming. So these iris pearls can coalesce with each other and form much larger iris pearls. Okay. The term here would be iris pearls, which is seen in chronic iritis, which is a granulomatous inflammation. And please remember it is due to invasion of lepra organisms. Okay. Now what happens is, as the leprosy becomes chronic, the important point would be there would be atrophy of the iris stroma. There would be absolute atrophy of the iris stroma, and the pupil would be myotic, or the pupil will become smaller in size. This is due to damage to the dilator pupillae muscle of the iris, and damage to the sympathetic fibers of the iris will ultimately result in a myotic pupil. So as you can see, this is tiny, and you can see by the arrowheads, by the arrow marks, these are the tiny iris pearls which are being formed at the pupillary margin because of the lepra organism. Okay, so it is mandatory to always look out for a slit lamp examination in case of leprosy because it affects mostly the anterior segment. Now, one more important part would be syphilis. So in syphilis, it affects again both the anterior as well as the posterior uvea. So again, the acute stage is a plastic iritis. Plastic here is nothing but outpouring of exudation iris, outpouring of exudates from the iris. So which should again be a non-granulomatous type. And the chronic stage would be a syphilitic granulomatous stage in the chronic stage. And posterior part, again, as I've said, it could be diffuse choroiditis or a multifocal choroiditis or just a focal choroiditis. So it could be any of these. Now, again, this is slightly important considering its ocular toxoplasmosis. So ocular toxoplasmosis, coming to it, it is the most common cause of posterior uveitis and 90% of focal necrotizing retinitis. So the patient here, again, because it is confined to the posterior segment, the patient presents with floaters and decreased vision. And suppose if there is spillover anterior uveitis, pain, redness, and photophobia can also occur. Now we'll straight away go to the picture here. Now what you can see here is, again, recollecting our active patch of choroiditis, there can be a whitish, yellowish white raised lesion in the choroid here. So, but you can see, you cannot see the patch very clearly. That is because there is vitritis or inflammation of the vitreous. Because of this inflammation of the vitreous, whatever active patch of choroiditis is there, that yellowish part, it is not very clearly seen. So this is nothing but headlight and fog appearance. The headlight is nothing but the active choroiditis patch, and the foggy appearance is due to inflammation of the vitreous. So coming back to the signs, a grayish white or whitish yellow lesion of retinal necrosis can be seen adjacent to the edge of a pre-existing chorioretinal scar which is healed and pigmented. overlying vitritis gives the headlight and fog appearance. Now, you can see that what in the first picture, like whatever active lesion you can see, it usually begins. What happens is, just going back a little in history of toxoplasmosis, when congenital toxoplasmosis occurs, what you can see typically are scars of the, usually a baby will be born with these scars, especially in the center, in the macular area. It will be usually seen in both the eyes. So you can have bilateral chorioretinal scars in the central area. And then when will you identify it? When the baby, when you realize that the baby is not seeing properly, the baby will come with defective vision, or the baby might develop squint. So all, because squint will develop because of the resulting amblyopia, the baby is not seeing properly. So all these can lead to toxoplasmosis. I'm sorry. All these can lead to identification of the baby having toxoplasmosis. So what happens is, the scar can be inactive for a very long time, but whatever parasite is there, it is still present in the choroid. So what happens is, after a point, maybe after, there is a second peak when the cyst will start rupturing and the parasites will release. And then what happens is, when the patient hits middle age, just adjacent to this healed scar, you can see development of a new active lesion of retinal necrosis or chorioretinitis patch. Okay. So all this chorioretinitis patch will start developing adjacent to the old healed pigmented scar. So there will be formation of a new active lesion here. So again, as I said, this is juxtapapillary retinitis, and then again this is a headlight and fog appearance. And sometimes what happens in AIDS patients or immunocompromised patients, you need not have a single foci of choroiditis like this, a single focus of chorioretinitis like this. You can have multiple foci of chorioretinitis, especially in immunocompromised patients. So that is what I'm referring to. Again, suppose if this uveitis is extending to the anterior part, you will have a non-granulomatous type of anterior uveitis. Now, herpes infection, as you might recollect in the cornea class, herpes infection will cause keratitis. Usually what happens is, in case of herpes infection, be it with varicella zoster virus or herpes simplex virus, usually uveitis is also seen in association with keratitis. But whatever uveitis we see in association with keratitis, it's not a granulomatous type, but it is just a very mild, acute, non-granulomatous type of herpes infection is seen here. So whatever keratic crespates are seen, they will be small and fine. The aqueous flare will be mild. And please remember, the hypopion can be blood tinged or hemorrhagic in case of herpes infection. So suppose the uveitis lasts for a long time with recurrences of herpes infection, then in long-standing cases, you can have complications like iris atrophy, secondary glaucoma, and complicated cataract. Okay, but in herpes infection, for treating the uveitis, you will treat them with steroids only. But suppose there is a very active geographic culture or dendritic culture which is staining positive for fluorescein, then you would not be using steroids until there is epithelial healing. Otherwise, the ulcer would progress very rapidly in the cornea when you start trying to treat it for uveitis. So be very cautious about treating a herpetic uveitis when there is an active corneal ulcer present. Now, what is CMV retinitis or cytomegalovirus retinitis? Again, the first line, it is the most frequent ocular opportunistic infection in patients with AIDS, especially. So again, because it is causing retinitis, the symptoms would be again floaters and decreased vision mostly. So as you can see, there is this whitish retinal lesion. This whitish lesions are nothing but due to exudations. There are lots of retinal exudates because of the ongoing necrosis, and there can also be lots of hemorrhages, as you can see in the picture. And you can also see there is lots of vasculitis or retinal vasculitis. There is retinal necrosis, there is retinal vasculitis, and there are lots of hemorrhages here. So all these will cause loss of fine fundal details, fine fundus details. You can only see the gross details. So this is typically referred to as a Pizza pie appearance. So there is whitish retinal lesion with hemorrhages and hard exudates, and also you can see retinal vasculitis. And as you can see, it's not spreading in a random fashion. It is spreading like a brush fire. Okay, it is like a wildfire or a brush fire pattern which is spreading in a specific manner. So all this appearance is known as pizza pie appearance. Okay, this is CMV retinitis. Now, what is acute retinal necrosis? Acute retinal necrosis is caused by varicella zoster virus, HSV, and CMV. Again, the symptoms are decreased visual acuity and floaters. Now, I will try to differentiate between these two. This is progressive outer retinal necrosis. This is acute retinal necrosis. The main difference is in acute retinal necrosis, the vitritis is very much marked. There is marked vitritis in acute retinal necrosis. In progressive retinal necrosis, the vitritis is very mild. Okay, it is a mild vitritis. And one more thing is, there will be, again, just as the name indicates, there are patches of retinal necrosis or whitish patches of retinal necrosis. But whatever retinal necrosis patches, as you can see in the picture, it is not an extensive patch here. These are just multiple foci of retinal necrosis occurring here. Okay, so these are focal necrotizing patches of retinitis in acute retinal necrosis. In progressive outer retinal necrosis, whatever patches you see, they are large, rapidly coalescing patches of retinal necrosis. Okay, so as you can see, look at this picture. It's a very large patch of retinal necrosis in this picture. These are focal patches. So this is marked vitritis, that is mild vitritis. These are focal patches of necrotizing retinitis. Those are rapidly coalescing large patches of necrotizing retinitis. So obviously, this case will be presenting with decreased visual acuity and some floaters, whereas this case would be presenting with rapidly progressive visual loss. Okay, so these are two important features. Progressive retinal necrosis is again usually very organism specific, occurs in immunocompromised patients, specifically by varicella zoster virus. This also occurs due to VZV, but also due to HSV and CMV. Okay, I hope it's clear. Even if you don't remember anything, please, you can just remember from the name itself, this is retinal necrosis, this is progressive retinal necrosis. So whatever you write, the retinitis is progressive, but the vitritis is mild. Okay. This is a picture of progressive retinal necrosis. You can also see there is mild inflammation of the optic nerve head also here. Okay. Because of this extensive retinal necrosis, in both the cases, retinal detachment is a very, very common complication. Okay. Now, what about fungal uveitis? In fungal uveitis, we'll go straight away to the pictures. This is ocular histoplasmosis, which is slightly important. Please remember, even if you can't remember anything, ocular histoplasmosis causes something known as histospots. Okay, it causes something known as histospots. So these histospots are nothing but atrophic spots which are present in the periphery, in the mid periphery of the retina. So these are atrophic histospots. Okay. These are small, yellowish white, and sometimes in later stages they might develop pigmentation. Also, what happens is, if this similar histospot is developing in the macular area, it becomes a macular histospot. So this macular histospot will cause a central macular scar. And again, the macula is the most important area for central vision. So if it is causing the central macular histospot and causes scarring, there will be a prominent decrease in visual acuity and fall of central vision. So this is ocular histoplasmosis. One late complication of the macular scar area is, suppose this macular scar will develop a break in the Bruch's membrane of the choroid, in the Bruch's membrane of the choroid, then there can be development of a choroidal neovascular membrane. It will be dealt in detail in the later classes. But please remember, you can have a macular histospot or you can have a peripheral histospot. Both of these are atrophic. Both of these will lead to scarring. But the center thing will lead to obviously more extensive scarring and more extensive loss of vision. This is about ocular histoplasmosis. So macular atrophic scar, peripapillary atrophic scar, punched out multiple chorioretinal scars may be seen in the periphery. Now, this metamorphopsia or defective vision can result when there is macular involvement. I hope I'm clear. Now, one more important part is HLA-B27 related uveitis. So, what are all the conditions related with HLA-B27? Those are ankylosing spondylitis, Reiter's syndrome, as well as something known as juvenile idiopathic arthritis. All these three conditions have arthritis and also there can be uveitis. So the uveitis here is usually non-granulomatous type of acute uveitis. Okay. So the uveitis is non-granulomatous and acute, but in case of juvenile arthritis, it can be chronic non-granulomatous variety. So because it is anterior uveitis, the symptoms would be similar to anterior segment part. There can be pain, redness, photophobia, blurring of vision, all symptoms related to anterior segment. And suppose there is very severe anterior uveitis, there can be lots of exudation and sometimes also a hypopyon. Now, one more thing is Behçet's disease. So this Behçet's disease is what happens. It is, if I'm not wrong, it's B51 associated. So this again causes mainly anterior uveitis. So all symptoms would be pain, redness, photophobia, decreased vision. If you remember Behçet's disease has, along with anterior uveitis, it has aphthous ulcers, genital ulcers. So mainly anterior uveitis, and the hypopyon seen here is usually very thin, and so it typically shifts with the position of the head. This is Behçet's disease. Okay. Again, treatment again as discussed for anterior segment could be steroids, mydriatics, and cycloplegics. Okay. Now what? How about sarcoidosis? Sarcoidosis, again, as we've tried to recollect, one of the important causes of intermediate uveitis is sarcoidosis. Sarcoidosis will also cause anterior uveitis. Anterior uveitis is a granulomatous variety. So what you can see are iris nodules, mutton fat keratic precipitates, and lots of aqueous cells and flare. And because of intermediate uveitis, there can be snowball opacities, as snow banking, snowball opacities, and vitreous string of pearls. When it comes to posterior uveitis, there can be candlewax drippings. Now, what are these candlewax drippings? You can see that whitish area is somewhere here along the vessels, the retinal vessels. So, whatever retinal vasculitis is occurring, there is sheathing of the perivascular vessels. Okay, it is occurring perivascularly along the retinal vessels, and it appears as candlewax droppings. Please remember, sarcoidosis involves anterior uveitis, intermediate uveitis, and posterior uveitis. Anterior uveitis is granulomatous type. Intermediate occurs, posterior occurs, and most significant symptom is candlewax drippings due to retinal perivascular sheathing. Okay, that is what you have to remember. That's it. Now coming to the last part. What is VKH syndrome or the Vogt-Koyanagi-Harada disease? So this VKH disease, first we'll try to look at these symptoms. So you see a patient who presents with vitiligo. He has poliosis or premature graying of the eyebrows and the eyelashes. And he also has alopecia or hair loss. These are like the other features. Dermatological features, he has alopecia, poliosis, and vitiligo. And then he presents with Features of meningeal irritation: he might have headache, he might have fever, he might have vomiting, neck stiffness, and we may also come with features of tinnitus, deafness. So all these signs of meningeal irritation along with the dermatological features, all these you have to suspect VKH syndrome. So coming to the ocular features, it will have a granulomatous type of uveitis. Again, very similar to sarcoidosis, the uveitis anteriorly is granulomatous type. And posteriorly, what happens is there can be exudative retinal detachment. Okay, the term to remember in VKH for posterior segment is sunset glow fundus. Okay, sunset glow fundus is where there is choroidal depigmentation and the fundus appears like sunset glow. So it is sunset glow fundus, and exudative detachment may occur, and anteriorly granulomatous anterior uveitis may occur. Enough. There's no need to remember too much about it. Okay. Now, one more important point would be Dalen-Fuchs nodules and formation of a choroidal granuloma. Dalen-Fuchs nodules form between the retinal epithelium, retinal pigment epithelium, and the Bruch's membrane. These are the Dalen-Fuchs nodules, and there are also formation of choroidal granulomas and multifocal choroiditis. So again, as I've said, alopecia, vitiligo, poliosis, deafness, tinnitus, signs of meningeal irritation, granulomatous uveitis, and suppose it's a chronic case, there will be obviously iris atrophy in case of anterior segment. In case of posterior segment, obviously you can have complications like cataract and stuff. So sunset glow fundus is an important term here, and exudative retinal detachments can also occur. Now, what is Fuchs uveitis syndrome? So what happens is, again, straight to the pictures, you can see the KPs or the keratic precipitates are very fine. So there is usually unilateral, very fine keratic precipitates with mild corneal edema. So why is this corneal edema occurring is, there is, I'm sorry. Fuchs uveitis, I'm sorry, this is fine keratic precipitates with heterochromia of iris. Okay. That is the iris of one eye is of one color, and the other eye there could be a different colored iris. Or because this is a non-granulomatous type, there is mild aqueous flare and fine keratic precipitates. And most importantly, in Fuchs uveitis syndrome, there can be neovascularization of the iris as well as of the angle. So this neovascularization of the angle is known as Amsler's sign. So whenever you do gonio, usually it will start bleeding. This is the Amsler's sign. So this is a chronic non-granulomatous type of anterior uveitis. So whatever features you can think of non-granulomatous, you have to remember it's a non-granulomatous type and write symptoms accordingly. Please remember heterochromia of the iris, and please remember there is neovascularization of the iris as well as the angle. So these three would be absolutely important terms, and then you can write your answer accordingly. This is the picture. Now the last part, what is Posner-Schlossman syndrome, also known as glaucomatocyclitic crisis? So what happens is, it usually occurs unilaterally and there are recurrent attacks of raised intraocular pressure. Usually H. pylori or Helicobacter pylori infection is implicated, and it can also occur in case of herpes. All these can lead to trabeculitis and might cause raised intraocular pressure. So you can see corneal edema, but otherwise usually the eye is quiet, but the intraocular pressure is definitely raised. And there can be very fine keratic precipitates. So treatment, to treat the uveitic part or the trabeculitis part, you would need topical steroids. And to treat the raised intraocular pressure part, you would be requiring anti-glaucomatous drugs. So this is about it. In the next class, you will be dealt with endophthalmitis and panophthalmitis and sympathetic ophthalmitis by Dr. Anusha. So that's about today's class. Please focus on intermediate uveitis and posterior uveitis mainly. The remaining, please focus in tidbits, specific types of uveitis. Look out for questions, but otherwise, most important parts to focus would be intermediate, posterior, anterior, end off, and pan off. Specific types, just go through this main important stuff. Okay, that would be sufficient. Any questions?
Translating.
No.